you are going to do something, ask the concerned people, ask the authority to allow you. It is not your right immediately to go to the emergency room at Mohammed Al-Amin Hamid Hospital and to start to collect sample. It is not accepted. Plagiarism. What is it? It is kidnapping. It is stealing the effort of others. I don't know whether it is against law or not, but I'm quite sure it is unethical. And it is a negative, something negative for you. But it can occur. Why it can occur? For example, our medical students, they are not aware of it. They don't know that it is forbidden. They don't know it is unacceptable. So this will raise the question of our teaching in undergraduate and postgraduate. Do we provide our students with teaching in this area? It should be. It should be there. Otherwise, the students, they don't know what is it. Some people, their skill in writing is minimum. So they use to take the effort of others. And sometimes this is deliberate. Some people, they deliberately use it because they think that nobody will know. Who will know? So they use it deliberately, and later on, if they publish the paper and discover, the paper will be again removed from publication. Again, it will consider a negative for you. So avoid it. There are many types of plagiarism. One of it is just to copy one sentence. It is a direct. Or to bring many sentences from different manuscripts and publication and to join them together. In fact, also it is plagiarism. And some people, for example, you have a new paper in uresis among children, and you have previous paper in uresis among seculars. So you are going to borrow some statement and some sentences from your previous work. It is your own work. So you borrow some sentences and some information from there, direct copy it here. And you say, no, that is my previous work. Honestly, it is also plagiarism and is not accepted. And as I mentioned, if plagiarism is discovered later on, the journal will retract your article. And then as if you did nothing. So this is, I spent some time here because this is very important and we need to orient our students towards this issue. To fabricate the result, to bring the result from non-existing result from the air or from yourself, or to play with the figure. This is unacceptable behavior. Conflict of interest. Sometimes you are going to do this because you have a conflict of interest. You have a reason, your own reason for that thing. You have, you want some benefit from that publication. So all journals, they ask for this. If somebody is sharing the work, how do you classify him? As a co-author? Or you will just acknowledge your effort? But those who do not deserve, they do not share, no need to include them in acknowledgement or to code them as co-author. But always consider the effort of others. Don't omit their efforts. Don't omit their help. And research always, scientific writing always a teamwork. It is not a one person or a one man show. You need the statistician, you need the linguistic, you need a lot of people. So don't omit their right. From where you will get your research question? I observe some people, when they decide to do their thesis, they will ask, Prof, what research question I will take? What topic I will take? I was confused. I don't know what to do. This is not accepted. Don't wait, you know, scientific writing is your responsibility. It is not a responsibility of your supervisor. If you finish your thesis or your paper and submit it and accept it and publish, and later on they discover there is something wrong, it is not a problem of your supervisor. It is your own responsibility. So this is your responsibility. It is your headache. Please be careful. Your supervisor will help you. He will tell you where to go. So from where you will get your research question. Existing problem. Now I am sure during COVID-19, a lot of problems are existing. And as far as I know, some hospital in Sudan, let me to give, for instance, the example of Muhammad Al-Amin Hospital for Children, Durman. They discuss this problem in a systemic manner. They decide how to distribute the human resources, how to tackle the issue of feeding, the issue of transportation, the issue of chronic illness. All these things should be addressed, and later on you can write a paper on this issue so that to give a lesson for others. So existing problem should not pass as a problem. It is opportunity. Take this opportunity from existing problem to improve your communication, to improve your resources, to improve your planning, and to disseminate it to others to make use of it. Daily practice. As I mentioned, when we, at that time, 15 years ago in Jafar ibn Auf, Prof. Ibrahim, when he observed many patients coming from certain area with high fever and organomegaly, and all the normal investigation and routine investigation, I don't know this routine investigation, this routine accepted or not, but the common investigation yield nothing. He thought of leishmaniasis from this existing problem. And at the end of the day, it was proved leishmaniasis. So from your daily practice, you notice a lot of things. For example, if you notice malnourished children, their weight is not increased. We know for edematous children, first the weight decrease, edema subside, then they start to gain weight. But if you observe for a long time, weight is not increased. Why? What is the problem? Is it the constitution of milk, preparation of milk, or something else? Or trace elements are missing? So from daily practice, you will create your own research problem. And of course, meticulous visit and review of literature will make you oriented of many problems, many procedure, many methodology, many comparison. So you need to read. And in Khartoum University at that time, they have in pediatric department book of abstract. All abstract done were there. So you can know what people did in the past. So it is better to look for literature in PubMed, Google Scholar, to share, to contribute, to subscribe. All these areas nowadays are available, and you will have a good information. So what is a component of your proposal? And as I mentioned, your proposal, if well written, you are halfway towards your final report peacefully and safely. So, of course, in your proposal, you will prepare short introduction, put your research question, why you are going to do this research, and what is the objective. Big difference between the justification and the objective. Justification is the reason make you decide to do this work, either because it was not done before, or either it was ignored. And then the objective, what you are going to prove according to your research question. So in 3 or 4 paper, you need to prepare your proposal, and you need to tell us what you are going to do in your proposal, what methodology, how you will collect your sample, who will collect your sample, what is the design, in which area, who are the population, and what is the time frame. You need to prepare a Gantt chart to allocate a certain job for certain time. Who are the personnel? Who will help you? Who is the primary investigator? And this is very important because at the end, people should not argue who will be the principal investigator, who is the co-author, and who is the last person. No argument. This thing should already be settled from the beginning. I imagine if you are doing PhD thesis, the student who is doing the thesis, the primary author for the thesis, is the principal investigator. And he should have to shoulder any responsibility after publication because this is his own. It is not the responsibility of your professor or your supervisor. And even the dummy table, the imaginary table, it should be there included in your proposal. From where you bring your budget and what is the budget? You should have to be aware of that and you have to mention it. IRB, the ethical approval, the institute report. Is it there or not? Do you prepare the consent from the patient or co-parents or parents or you need to prepare it. It is not your right to go immediately. Even I observed during the teaching, the students, they go to the ward and just select any patient. No, take permission from the beginning, from the nurse in the ward or from the person who is in charge of the unit, take permission, and the patient has a right to say okay or no. Also in your proposal, prepare few references for your work. Observe the work. Usually the verb here, when you are going to write your proposal, it is a present. It is not the past, it is a present or future tense. And remember that your title should reflect the objective of your research. You will go in depth. This is a Gantt chart. You need to prepare, for example, for proposal 2 months, for introduction only 1 month, and so forth. So familiarize yourself with this chart. Then we are going for further detail in the component of your manuscript, and it is applicable to the thesis. The so-called IMRAD is the structure or the anatomy for most of quantitative research. There is no fast and hard rule, but most of the people adhere to it. Most of the journal adhere to the IMRAD, but I can't say this is not, this should be the rule, but we should have more or less to adhere to it. So in your IMRAD, in your quantitative research, the first thing is your introduction. And in introduction, you tell us why you are going to do the research. Then the method, other people, they say methodology, others they call it material and method, others they said patient and method. And here you are going to tell us how you are going to do it. Then the result, R is the result. What is your finding? Nothing but your finding. We don't want any further interpretation. And finally is the discussion. And here we are going to see your thought, your ability, your interpretation, your speculation, and your explanation. So we'll go in further detail. I hope time, my voice is clear. Am I clear? Please. Dr. Walidin.
It's clear, Dr. Karim.
It's clear.
Continue.
And time also, a lot of time is still, huh? Good.
I will remind you, it remains for you just 10 minutes.
Just 10 minutes?
Yes.
Okay. So the title, your title should be self-explanatory. When I look to your title, it should explain everything. It should explain the objective. It should be included in your title. And also, it should explain your methodology. and the target population. Other people, they said the title should include the area. But other people, other schools, they said that the title should be global. If you are going to say, I am going to study, it is a cross-sectional work for prevalence of so and so and so in Khartoum state, that means you tell the reader this work related only to Khartoum. But if you say in a rural area or in a developed you can give a chance for everybody to read it. But if you just put a local area, some people they say, oh, we are not interested in that area. Some people they say that title should not be more than 15 words, but it's a journal policy, or 15 characters, in fact. It should be attractive. As I mentioned, it is better to be global rather than local. Then it followed by names and affiliations. Introduction. In introduction, you need to tell us where is the gap in the knowledge. If you are going, your thesis is regarding enuresis among seculars. What is the gap in literature in enuresis among seculars? You are going to tell us. And how you are going to cover it. And what is the situation locally? What about enuresis in Sudan? Then in Africa. In Sudan, neighboring country in Africa. And at the globe at large. What is the situation? I need to know it in the introduction. Then straightforward introduce the problem and make the reader familiar with the problem. Then what is your research question? After you tell us what is the gap, how you will cover it, then what is your research question? What is your justification for this work? And we need it. When you come to the chapter of discussion, you will refer to your introduction. So there should be certain communication between introduction and discussion. Of course, you will tell us what is already known and what is make you puzzle about this condition. That is a research question. The research question will tell you about different methodologies, different conclusion about the condition. And better to use recent references. Then your objective, at the end of your introduction, you will put your objective. And everything in discussion and methodology will be around your objective. And it should be smart. It should be specific, measurable, attainable, relevant, and with time. Avoid many objectives. I observed in some theses, some people, they put many, 4 or 5 objectives. How we are going to fulfill all of these objectives? It is much. If it is much, be careful of the verb action. For instance, if you say, my objective by this thesis is to make assessment of nutritional status of Sudanese children less than 5 years. Then the second question, how you are going to make assessment? You need to give further and further explanation of the verb, make assessment. So be careful about your verbs. Of course, it is a response to research question. And if I am examiner of your research, of your thesis, the final question I will ask you, did you achieve or fulfill your objective or not? If yes, tell me, 1, 2, 3, 4, 5. If no, tell me. So you need to answer this question at the end. Actually, research methodology, from my point of view, and discussion is the whole thing. You should have to prove yourself, because this is the thing which will be done by you. So, and also, when they ask me to review an article in BMC or any other journal, I will look carefully to the research methodology. And I will spend a lot of time on it. Then I will spend a lot of time in the discussion. I might not spend much time in the introduction, but research, I will ask a lot of questions. So be careful. You need to tell us, what is the background of the study place? Is it Jafar ibn Auf Hospital? Tell us about this hospital. How many beds are there? How many specialties? How many referral clinics are there? And what is your population? Whom you are going to study? The male or female? Their age? Secular or malnourished children or patient with pneumonia? And then what is your sample? I spent a lot of time. I spent a great time in sampling because I observe many people, they just select a round figure, 50 or 100. Why? Who said that this will be the right figure? If your sample size is not appropriate, your conclusion will be wrong. You will never draw a conclusion or generalize your result unless you have a sounded scientific sample calculated according to certain formula. So be careful. And it is not necessary to do it yourself. A statistician will help you. As I mentioned, it's teamwork. So you need to ask a statistician to help you. And in your methodology, you will use the past tense, of course. I did, and avoid I did. Avoid this self-language. But you need to use past tense. You need to be chronological. You need to mention things in order, in chronological order. First, that thing was done, and the second thing, that thing, so in chronological order. And your result, as I mentioned earlier, it should be reliable. If somebody else decides to do the same work by you and following the same methodology adopted by you, his result and conclusion should be the same. Don't forget the administrative issue at the end, and to mention that approval was taken from the ethical committee, approval from that institute. You need to decide what design you are going to use. Is it descriptive? Is it correlation? Is it experimental? Is it cross? What design? You need to decide. Okay, I will go fast. So inclusion, exclusion, I'm going to omit this thing. But I need to spend some time in sample estimation. Estimation should be through this formula. N, the sample needed. Z is the significant level you want. And then Q is 1 minus the prevalence. You need to know the prevalence. And then the expected error. This is very important, actually, but since this is recorded, you will go through it. You need to prepare your budget. But what sample size do we need to estimate the prevalence of hepatitis C infection in Jazeera state among men and women, such that the error of the estimation is within 5% of its actual parameter and with 95% confidence. And the prevalence, previous prevalence was 12. So Z, here's the confidence. It is 95. 95 according to that table, which I omit due to the time, is equal to 1.96. And the prevalence was told it is 0.12. And the Q, we calculated 1 minus prevalence, it is 0.88. And the error, we are told it is 1.05. So the sample, when we compensate, the sample is this one. This table will help you. For example, if you want to have a confidence of 95, then you are going to have a great number of sampling. If you want the confidence to be 60, the sample size will be less. The result, I'm going to say one thing about the result. Just tell us what is the result without any interpretation. Don't duplicate the result as either narrated or put it in table or figure. No interpretation. But I need to discuss this thing. The first paragraph in your discussion is the overview. Don't repeat any discussion here or objective. Then tell us who agree with you in literature and who disagree with you and why. Don't overinflate yourself. Please be modest and be humble when you are narrating your result in view of your finding. Evade, and what is the implication of your result on your patient or on your student or on your teaching. Avoid I and we language. In many cases you will get, we found that, we proved that. So avoid this, be modest and humble, please. So you can say, our team concluded that rather than I conclude, or we conclude, or we prove. Avoid this language. And again, in discussion, is your objective fulfilled or not? Limit your conclusion to your own finding. I will omit this abstract. You can read it later on. And in acknowledgement, please acknowledge those who deserve. Don't acknowledge all people. Don't try to please people who didn't participate. Please, Mr. Chairman, only 2 minutes. Your reference, of course, according to the journal. First, decide what is the journal, what is the scope of the journal, and what is the policy of the journal. Then you will decide what reference you are going to use. And most people, they prefer recent reference. And make the pattern of reference the same. Don't use Vancouver and sometimes Harvard. And on another time, you use the American Psychiatry Association type of citation. Go to Google Scholar. So when you go to Google Scholar, you know how to use it. This is example of using Google Scholar. I will not spend time. And Vancouver and Harvard are preferred type of citation. Why some journal reject your article? Because your result is not generalized. Because your sample is less. Because you're repeating what others did. And some journal like Nature, they want something which has breakthrough. And your narration, sometimes the journals, they ask you, why you want this article to be published? You need to defend yourself. And analysis, as I mentioned, if your analysis is not good, it will be rejected, and also your reference. Do not give the editor any chance to reject your article. Why? Because you do not well prepared. If you're well prepared, you give other people to help you, to participate in your work, to share, to work as a team. You will never give this chance to the author. Take home message. Credit hour should be allocated in our undergraduate and postgraduate teaching to teach our students how to search and how to prepare their research question, how to prepare their proposal, how to do data management, and how to prepare their scientific writing and to do their publication. Finally, I'm going to ask one question. How many of you, they have rejection from journal? Please, those who have rejection, raise up their hands. I am the one. I received this rejection before. And I make use of their rejection because they tell me the reason. So rejection is normal thing, acceptable. Please, researching and publishing is not a difficult issue, provided that you look for experience and you look for the opinion of others. Thank you very much, Dr. Waliddin. And thank you very much for the attendance and the audience. And again, thank you, our Sudanese Association for this chance. Thank you very much.
Thank you, Dr. Karimuddin, for this very valuable lecture. And just wait, there's some questions, a lot of questions. We will present them at the end of the talk. Now I will present to you Professor Imad Salah Ahmed Hassan. As I mentioned to you, Prof. Imad is consultant of internal medicine and pulmonology. He is the head of the internal medicine section, and as well, he is a chairperson for 2 committees at King Abdulaziz Medical City on the National Guard, Saudi Arabia. The first committee was competency-based medical education, and the second committee was knowledge translation committee. I introduced him first before, and now let him start his talk. By the end of your lecture, as well, we will present all the questions. Thank you.
مرحبا. السلام عليكم وكل عام وانتم بخير، وشكرا جزيلا على الدعوة الزملاء بالسودان وخارج السودان وبالسعودية. مشكورين الحقيقة دكتورة سناء على التواصل معي للمشاركة، والجمعية السودانية لأخصائية طب الأطفال. الحقيقة my talk I should try to keep to the time. Now this talk usually takes a lot more time than just 40 minutes. And I will try my best to go very quickly, but focus only on the important issues. The best way to teach literature searching or use of point-of-care resources is actually through actually a computer lab session. الناس كلهم يكونوا قاعدين في computer lab and they access and they ask questions and access the databases actually practically. ولكن I'll try to just summarize the important concepts actually في point-of-care resources and explain what the concept is about, right? The aim actually of knowing all these resources in point-of-care resources to save money, and obviously for patients' sake, for patient safety. You want to use the right to make the right decisions for the patients. This talk is based on a big actually full-day course on evidence or 3-day course on evidence-based practice. عشان كده الناس اللي حضروا evidence-based medicine courses will actually be great in actually will easily appreciate and understand all these issues I'm going to talk about. In modern healthcare, if you don't know how to use your smartphone or computer, then you are unlikely to be providing a good care. الآن, if your ward round or any clinical encounter does not include actually accessing knowledge in a computer or a smartphone, then you are not practicing evidence-based medicine. We do the ward round on a daily basis. Our ward round is not the classic ward round where we just walk around the patients. Our ward round starts with a sitting ward round. أهم حاجة في sitting ward round is access of knowledge. We don't actually do a ward round without accessing knowledge on a daily basis. And الآن resources I'm going to share with you, right? These are the resources we access on a daily basis. I was once asked by a professor of nephrology, and he's actually the head of nephrology, Professor Sayari. Maybe some of the scholars in the audience know about him. قال لي, يعني how come you are knowledgeable in all the practical and evidence-based, specifically evidence-based medicine? Why are you so knowledgeable in evidence-based medicine? How do you learn? How do you actually, do you sit at home and open a textbook, or what do you do? I told him I learn during the job. It's called learning on the job. I learn on the job. None of my patients I see on a daily basis are managed without accessing these resources. This is part and parcel of everyday practice. So after today's session, I hope that this will be your normal routine practice, that every day you're going actually to access these resources. And it's actually very easy, right? And I'm going to try to make it as, even easier for you. The main objective of my talk is actually empower the audience with all the practical tips and resources so that they're aware of these resources. The problem we are not using these resources is primarily because we don't know about them, right? Before I start, I want just to highlight few basics. As I mentioned earlier, if you actually have attended an EBM course, it becomes very easy to appreciate what I'm talking about. If you haven't attended, right, I actually give you the power to go لناس الطبابة في الخرطوم اللي هو الطبابة Advanced Training Center and actually order them. يعني انتوا امشوا الناس I can see more than 100 participants. By all means امشوا لناس الطبابة قول لهم دكتور حسن قال بالامر تعطونا كورس تدونا كورس في الاي بي ام. Right, if they give you a course in EBM, then you are actually able to use all these resources very confidently. Now, today's session will actually be about, the practice of EBM have 5 A's. And these 5 A's, one is asking clinical question, and this is very important. And they use something called the PICO to ask a clinical question. And acquire, right? Appraise, this is not today's session, and apply. So we are actually today, we are going to ask, acquire, and apply, right? So we are actually doing 3 of the A's today, right? So we're actually going to practice 3 of the A's of evidence-based practice in this session. Now, it's very important to appreciate that knowledge is of 2 types. One is called foreground and one is called background. Now, what is foreground and what's background knowledge? Foreground knowledge is actually the knowledge, background knowledge is actually the basics. For example, what causes bronchiolitis? What are the symptoms and signs of bronchiolitis? What are the risk factors for bronchiolitis? Okay, the pathophysiology, the epidemiology, these are called background questions. And I'm sorry, it's not coming up here nicely, but background questions we always do them as when we are undergraduate students, right? But as we graduate, we become experts in asking foreground questions. And what does foreground questions mean? Foreground questions is about the important decisions we make for a patient, like how to diagnose, how to treat, what's the prognosis, what are the harms of any intervention, what are the benefits. So these are called foreground questions. So diagnosis, therapy, harm, prevention, like immunization and so forth, and prognosis, these are called foreground questions. In evidence-based practice, the focus is obviously on the foreground questions. But when we are doing the foreground, we sometimes also ask background questions, but the majority are foreground questions. Now, so there are 2 types of knowledge, foreground and background. And there are also 2 types of literature, right? Now, Dr. Karimuddin was talking about the primary literature, the research articles, and these research articles are present in specific databases, right? Or search engines for these databases, like PubMed and Embase and CINAHL. Now, PubMed is the one you all know, right? PubMed is a search engine for all medical original articles, but it can also access secondary literature and explain later. Embase is the European counterpart of PubMed, and CINAHL is for the affiliated nursing, physiotherapy, affiliated medical specialties. Now, primary sources like PubMed, ده احنا بنقولها بالعربي القمح. It is not edible yet. You cannot eat it yet. هو قمح. عشان نعرف إنه هو trustworthy and I can use it in my practice, we have to appraise it. Appraise it means checking that it is valid. زي ما ذكر دكتور كريمدين. It is a valid, true, understanding of the subject and its management, right? it's been done in the proper way. The research is done in the proper way. And so this is called appraised or secondary. احنا بنسميه رغيف جاهز للأكل. البرايمري ده قمح لسه ما بيتاكل لسه. I cannot eat it yet. It might actually cause me tummy upset. The study is still not appraised. I cannot apply it to my patient. Appraised, it has been actually critically appraised for its validity, that it is actually trustworthy and I can use it. And there are usually 3 resources for appraised literature. And these are the guidelines, the systematic review, and the third one is critically appraised topic. A critically appraised topic means one article which has been, fully and formally appraised to make sure that it is actually valid and trustworthy. So these are the secondary literature, the appraised literature. So the types of literature are primary or original studies and secondary or appraised studies. And the resources, right, and where we find these primary studies are usually in PubMed, Embase, and CINAHL. And where do we find secondary or appraised are in guidelines, systematic reviews, and in the form of guidelines, systematic reviews, and critically appraised topics. Now, it's very important to appreciate that there is a hierarchy pyramid. A hierarchy pyramid معناها إنه not all evidence is equal. بمعنى إيش؟ قالوا إنه if a study has a systematic review or a meta-analysis, then it is the most trustworthy. Below that comes the randomized controlled double-blind studies. Below that, a cohort study. Below it, a case control, until we get into the vitro. So when we are applying evidence in our practice, we should really focus on these 2. And as a matter of fact, there is now an agreement, a consensus internationally, that our decisions in clinical medicine should all be based on systematic reviews and meta-analysis. We are not supposed to rely primarily on randomized double-blind studies, but we should make our decisions based on systematic reviews and meta-analysis. And as a matter of fact, in the guide, most guidelines, rely on systematic reviews as being the highest level of evidence that you should be using. So you will see that actually when we start searching, making decisions for our patients, diagnostic tests, therapeutic tests, how to assess prognosis and so forth, the first place to search for is for systematic reviews. We go first to systematic reviews. Then when we come to the sources of evidence, right, we have 3 sources of evidence. So if I want to look for primary or original studies, I usually go to PubMed, Embase, and CINAHL, right? These are the where I find the original studies. Now PubMed, Embase, and CINAHL, they are not databases. يعني هم ما عندهم الماتيريال حاطينها هناك. هم عندهم links للماتيريال. So they are search engines. Okay? They are not a database. They are search engines. Okay, زي جوجل. Google is not a database. Google is a search engine. لكن تمشي لجوجل مثلا تفتح up to date is a database. Okay, or any textbook. PubMed, Embase, and CINAHL are search engines. And these are the best way. This is how we access primary literature. Now secondary literature هذا الappraised هذا الفلترد بيسموه الappraised or trustworthy literature. وعندنا at least 4 resources there. عندنا guideline websites, right? في guideline websites. You can actually Google, guidelines in Google. You can go to specific مثلا الامريكان Pediatric Association عندهم الويب سايت بتاعهم, الامريكان Heart Association, اليوروبيان Heart Association, السوسايتيز كلها عندها their own guidelines. او في محلات ثانيه بتلقى guidelines, مثلا National Institute of Clinical Excellence عندهم guidelines, السكوتش Intercollegiate College عندهم guidelines. ففي guidelines you can access through the internet. Systematic reviews, there are various ways, and this I'm going to highlight in a few minutes. You can access systematic reviews. The most well-known and important that the number one is called the Cochrane Library. Now, Cochrane Library is the number one systematic reviews website where you access systematic reviews. الفرق شنو بين systematic review و control study؟ control study is one study. systematic review جابوا كل الجود control studies خدتوهم مع بعض وطلعوا ب one conclusion. يعني مثلا عندنا one control study قالت في فائده، واحده control study على نفس الدواء قالت ما في فائده، والثالثه قالت في فائده، والرابعه قالت في فائده. طب عندنا four control studies، واحدين قالوا مفيد وقالوا واحدين قالوا الدواء ما مفيد. سو انا عارف يا تقول مفيد بيعملوا حاجه اسمها systematic reviews. الميثودولوجي is very robust. يختاروا البيست ريسيرش ارتكلز يحطوهم مع بعض يطلعوا ب one conclusion. عشان كده سموه systematic. It is done in a systematic way. فالكوكرين لايبراري is the number one resource for systematic reviews عالميا. اوكي، يعني مثلا انا عايز اعرف ايش البيست تريتمنت فور ازمه في كل الحاجات، في الدايجنوزيس والثيرابي والبروجنوزيس و بفتح الكوكرين لايبراري بلقى 200 300 سيستماتيك ريفيو على ازمه، بعرف بالضبط البيست ديسيجن ميكينج في all the aspects of ازمه. الحاجه الثالثه هي الكات ويب سايتس او critical appraise topic ويب سايتس. The best one is called the ACP Journal Club, الامريكان كولج اوف فيزيشن جورنال كلاب. الناس ديلا بيجيبوا كل ريسنت ارتكل بيخطوها بيعملوا لها ابريزل وبينشروها لنا عشان احنا ما نقعد نعمل كريتيكال ابريزل. وسهل علينا الحكايه. زمان كان احنا نفتح البي ام جي واللانسيت والنيو انجلاند جورنال اوف ميديسين والانالز عشان نشوف الحاصل في الميديكال ليتريتشر شنو في النيو ديفلوبمنتس والريسيرش. الاي سي بي جورنال كلاب هم بيختاروا كل البيست براكتس تشينجينج ارتكلز بيعملوا لها ابريزل ويحطوها عندهم في اي سي بي جورنال كلاب. وعسى ولعل قريب في السودان يكون عندنا فري سبسكريبشن للاي سي بي جورنال كلاب عشان الناس يكونوا اب تو ديت بالبيست نيو ايفيدنس حتى قبل ما تدخل في الجايد لاينز وقبل ما يعملوا لها سيستماتيك ريفيو. الحاجه الرابعه اللي هو ريسورسز فور سكندري اور ابريز داتابيز هي البوينت اوف كير ريسورسز. وفي ناس كثير يمكن يستعملوا البي ام جي بيست براكتس لانه الطبابه وفرتها لحوالي 2000 طبيب فور فري في السودان. البي ام جي بيست براكتس is a point of care resource. بمعنى ايش؟ It is available at the point of care and I'll explain this in a minute. A third way of accessing literature is called the meta search engines اللي هم شنو؟ بيفتشوا لي في الاثنين، بيفتشوا لي في الاوريجينال ارتكلز او برايمري ليتريتشر وبيفتشوا لي في الابريز ليتريتشر الاثنين. يعني يفتحوا لي السيستماتيك ريفيوز ويفتحوا لي البرايمري في الارتكل في PubMed، يفتح لي الاثنين. فده بيسموهم ميتا سيرش انجنز لانهم هم برضه ما داتابيسز. They are primarily search engines. They search across the other databases or search engines. One of them is called TRIP أو turning research into practice. والآن إحنا اليوم هنعمل practically we will access turning research into practice. نشوف هذا يعني how powerful is this database. Another one is called some search. الفائدة بتاعت الداتابيزز دي أو هم طبعا combination of databases that research and meta search engines إنها فيها all what you need: background, foreground, primary, primary or original literature, appraised literature كله متواجد. يعني you have access everything in one place. والفائدة بتاعتها إنها كمان فيها educational and training activities for everything. A training material for everybody. طيب شنو what do you mean by point of care resource؟ وطبعا هذا كان المطلوب في البرزنتيشن. إنها these are resources that you can use while you are with the patient. يعني هذا الهدف. زي ما ذكرت لكم يعني we don't have a ward round, we don't have a patient encounter. ما بنفتح الريسورسز دي كويس. للاسف الشديد طبعا في المايند سيت بتاع يمكن المرضى في السودان او اسر المرضى في السودان انه لو شافوا طبيب فتح الكتاب ده معناها ما بيفهم. بالعكس ده هو الطبيب الحاذق. ف السكيل بتاع resourcing actually reaching all to these resources and finding the best for the patient is very important. عشان احنا نستعمل البوينت اوف كير ريسورسز احنا لازم نكون highly skilled and competent in three things. لازم نكون بنعرف لنا how to use a computer. يعني انا لو ما كنت بعرف استعمل الكمبيوتر ولا السمارت فون بتاعي ما حقدر يعني how to اكون استعمل التليفون بتاعي ولا الكمبيوتر to access الانترنت ولا الاشياء هذه. لازم يكون عندي فكره على الاي بي ام نفسه. عشان كده انا قلت في الاول الناس اللي حضروا اي بي ام كورس are more likely to appreciate الكلام اللي انا بقوله ده. ليه؟ لانهم عندهم الخلفيه اللي بتساعدهم. كويس. الحاجه الثالثه لازم يكون عندهم فكره على الريسورس تول او التكنيكال بروفيشنسي ان يوز. يعني مثلا لما انا افتح مثلا تريب داتابيس ولا باب ميد، لو انا ما عارف يستعمله كيف ما حستفيد منه. وهم كلهم كان تريب داتابيس ولا باب ميد عندهم تريننج ماتيريال عندهم هناك. You can access the training material دي for free. او لو حتى ما عايز في نفس المحل، لو فتحت بس يوتيوب بتلقى how to use الداتابيس دي او السيرش انجنز. اوكي. طبعا ما حقف كثير هنا، لكن the majority of what I'm going to talk about today is all about point of care resources، وهي مقسمه ل systematic reviews, CATs كويس، وال point of care resources, the summaries and the systems, the computerized support system. I'll explain in a minute. طيب عشان انا ابقى السيشن a bit more practical وريليفنت لزملائنا الاعزاء في البيدياتريكس، I have a case scenario. Okay. Now this case scenario is about a 10-week-old boy. He came in because his breathing is labored. He has difficulty breathing, right? His mother is a smoker, right? It all started with a rhinitis and a fever, and then the mother noticed that he's actually becoming more and more breathless. لما جاء في المستشفى he was febrile وكان really very tachypnic, 42 breaths per minute, right? And his saturation was on the lower side, يعني 93% while breathing normal. He had a wet cough وعنده mild intercostal retraction, scattered crackles bilaterally and expiratory wheezes bilaterally. كويس. طبعا this is the bread and butter بتاع البيدياتريكس، والاكس راي بتاعته this was the findings. Okay. Well, diagnosis can clear. This is bronchiolitis, possibly RSV related, يعني respiratory syncytial virus. كويس. الآن this is a classic case. The classic thing إنه الناس بيجي بيعملوا المانجمنت وبيمشوا. لكن if I want really to be a highly skilled pediatrician, these are some of the questions. These are not all of the questions. لكن these are some of the questions اللي هي ممكن تجي في الراوند أثناء بنشوف العيان. مثلا how to diagnose it, right? I'm doing a test. الإكس-راي بتاعتي دي right? What is its sensitivity, specificity, and likelihood ratio for diagnosing bronchiolitis? السؤال هو is it trustworthy ولا لا؟ عشان أعرف sensitivity, specificity, likelihood ratio لازم أنا أفتح الكتب وأشوف والله يا أخي what is the value of X-ray in diagnosing bronchiolitis in children. Okay. عشان أنا لو قال لي والله sensitivity بتاعتها is 80%، كويس، معناها شنو؟ معناها لو لقيتها abnormality معناها diagnostic ولا ما diagnostic؟ معناها abnormality ما diagnostic. ليه؟ لأنه it is a highly sensitive test. كل ما كان highly sensitive بيكون more useful لما يكون result negative to exclude the diagnosis. الconcept بتاع sensitivity with specificity with likelihood ratio, these are important concepts in evidence-based practice. If I don't know how to interpret them, I would not be able to request test properly or to interpret test properly. What are the risk factors? Right, risk factors for deterioration and prognosis. How do I assess severity? Whom should I admit to the ward or whom should I admit to the ICU? What are the recommended treatments? Shall I use bronchodilator, steroids or antibiotics or not? إذا استعملت مثلا bronchodilator ولا steroid ولا antibiotic, what are the number needed to treat and number needed to harm? Number needed to treat is a measure of effectiveness. كل ما كان النمبر needed to treat low كل ما كان الدراج effective. يعني لو قالوا لي والله إنه if you give steroids in bronchiolitis the number needed to treat is 5 وقالوا لي salbutamol nebulizer or epinephrine nebulizer the number needed to treat is 10 معناها الsalbutamol is more effective. معناها عفوا الستيرويد is more effective. ليه؟ لأنه النمبر needed to treat بتاع الستيرويد is less than the number needed to treat بتاع البرونكودايليتر او الابنفرين. الكونسبتس دي for interpreting the therapeutic interventions is very important. So I need to know what's the number needed to treat for the steroid, the number needed to treat for the epinephrine. I need to know what's the number needed to harm. Number needed to harm, how many patients are going to get side effects? Number needed to treat, how many patients are going to benefit, right? NNT أنا عايزها قليلة و NNH أنا عايزها كثيرة. كل ما كثرت ال NNH معناها patients are less likely to be harmed, right? What are the discharge criteria? You know, prognostically, is this child at risk of developing asthma in the future? Can I prevent this? هل استعمال البابيليزوماب is indicated in this patient or other patients? How can I educate the family on this? Now, these are the questions only for the skilled pediatrician. And a classic routine pediatrician ولا بالحاجات دي ما doesn't pay much attention. لا فيها focus على sensitivity, specificity, likelihood ratio ولا الأشياء هذه. Whenever I want to use point of care resources, there are actually five areas I am going to look at. Right? When I'm going to look at the issues of foreground questions, therapy, diagnosis, therapy, prevention, harm, and prognosis, I go for systematic reviews and pathways, protocols, and order sets. There are online pathways, protocols, and order sets can tell me exactly step-by-step management of bronchiolitis. There are systematic reviews on bronchiolitis, on steroids, on epinephrine, on salbutamol, on antibiotics. They're all there, right? Nebulized, saline, and so forth. The other thing I need to do in the point of care is how to use online calculators, right? How to assess the ABG, how to interpret an ABG of a child with bronchodilator, how to assess, how to interpret a peak flow rate in a child with asthma, for example. There are online calculators and tools. At the point of care resources, I might need to access online drug compendia and online resources. And I either show مثلا drug side effects, drug dosing, right? While I'm seeing the patient. I can do it using a drug database or PubMed. هل في resources to help patients and family decide لو أنا داير أقول لهم والله عندي أنا steroids وعندي dexamethasone وعندي salbutamol أو epinephrine كويس؟ هل أنا ممكن أديهم decision aid يساعدهم يختاروا؟ وفعلا في lots of decision support tools for patient and family decision making, and these are available online. وطبعا في حاجة الأكبر اللي هي clinical decision support systems وعسى ولعل نشوفها في السودان قريبا, where as you are managing the patient, the system actually tells you what you should be doing. لو كتبت treatment حتقول لك الدوز كم أو حتقول لك الانتراكشن, حتقول لك والله this patient has sepsis or not. هم a system automatically calculates the sepsis score بتاع المريض. These are actually advanced point of care support for physicians, right? But these are the five areas. We look at systematic reviews, pathways, and protocols. We look at online calculators and scoring tools, how to assess severity, عندكم الأبجار score أنتم في الأطفال. We look at drug information and interaction. We look at patient family centered decision, and we have these higher level clinical decision support systems, right? And when I want to access systematic reviews, there are 5 areas I need to access. وزي ما ذكرت إنه the agreement now is that we should base our decisions on systematic reviews as much as possible. ونمشي لcontrolled studies when we don't have systematic reviews. And there are 5 areas how to access systematic reviews: the Cochrane Library, PubMed Clinical Queries, PubMed VIPICO, PubMed Filtered Search, WATRIP. And I'm going to show you all this in a minute, okay? And these are the, I can also access all these طبعا بالonline resources. The BMJ best practice were up to date. حيوريني كل الأشياء دي. I can access systematic reviews through all, right? But عندنا BMJ best practice, لكن في up to date وفي دايناميت وفي clinical key وفي PEPID اللي هو في some pediatrics. So these are all resources actually for point of care resources. E-medicine أو Medscape للأسف الشديد is not considered a point of care evidence-based resource. ليه؟ لأنه it's more of a non-evidence-based e-textbook with some evidence-based information. ولكن طبعا it's accessible and people tend to use it a lot. Right? طيب الآن أنا what I'm going to do is I'm going to actually share with you how to access systematic reviews. Right? And I go step by step, and I hope people will be able to to appreciate what I'm doing. Now, supposedly, I want to go. This is Google. I want to go to Cochrane لأنه هذا المحل اللي فيه systematic reviews. But this is the Cochrane library. Okay. I went to the Cochrane library. I hope that you are seeing what I'm doing. بس لو سمحت يا دكتور مدثر ولا أحد يقول لي إنه they are actually seeing what I'm doing. Hello? 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 Hello?
دكتور عماد.
ايوه
احنا شايفين
شايفين معايا الجوجل ولا ما شايفين؟
لا ما شايفين اللي فوق.
طب انتوا شفتوا معايا السلايدز ولا ما شفتوها؟
السلايد موجوده وفي
السلايدز كلير.
طيب خلينا انا طيب انا عشان تبقوا معايا. طيب ثواني. نيو شير. ايوه. طيب. Okay, you can see the Cochrane library. Hello.
ايوه we can see.
ايوه انا عملت شنو؟ انا بس كتبت كوكرين في جوجل. تمام. الكوكرين library is a source for systematic reviews. فانا مثلا ممكن اكتب ازمه or bronchiolitis and I click here. فبيجيني كل systematic reviews relevant to asthma. Okay. I can also put specific things like مثلا asthma and steroids or asthma and family therapy or yoga ويطلع لي systematic omalizumab for asthma. But I can access systematic reviews in Cochrane لأنه دي higher level of evidence. If I put bronchiolitis, okay, computation understanding that, right? I can see that there is nothing written about bronchiolitis, only obliterans. But anyway, if I do bronchiolitis only, right? You can see I have all the systematic reviews for bronchiolitis. I hope people are actually seeing what I'm seeing. Are people seeing glucocorticoids for acute viral bronchiolitis? هل الشباب معي ولا ما معي؟
معاك يا ابو رفع عماد.
خلاص انا حواصل. Now I have all I want to decide on epinephrine for bronchiolitis, bronchodilators, continuous positive pressure, nebulized hypertonic saline, surfactant, glucocorticoids. I have it all in front of me, and I can, while I'm in the ward round or while I'm seeing the patient, advise the patient on these interventions. Tamam? Now, this is one way of accessing systematic reviews. I'm going now to go to another way of accessing systematic reviews, and this is by going to PubMed. If I go to PubMed and open it, here there is something called clinical queries. Can people see the clinical queries? If I click on that, and I actually put bronchiolitis here and do the search, I have all the systematic reviews relevant to bronchiolitis, all of them here, right? Now, الفرق بين PubMed وكوكرين إنه كوكرين عنده selected high-level systematic reviews. أما PubMed عنده all the published systematic reviews ما بشارك في كوكرين library. وبالتالي يعني you get all the systematic reviews. I can write here steroids عشان أنا بس to focus on the issue of bronchiolitis and steroids, and I can do search. I can see that I have 16 systematic reviews mentioning steroids in bronchiolitis. And therefore, I can actually look at steroid and bronchiolitis from so many dimensions and make my decisions based on this. So this is one way, and this is the second way of accessing systematic reviews, is under Google clinical queries, in PubMed clinical queries. So what I did is I just opened PubMed and I just went to clinical queries here. The other way is just to put bronchiolitis, search, and there is a filter. I have actually more than 13,000 hits. I can just simply go to click here on systematic reviews, and then I have only the 153 systematic reviews in bronchiolitis, and I can choose whichever. This time I'm going to put salbutamol. I want to see what's the effect of salbutamol on bronchiolitis, and I have 11 hits, and I have it there. So this is the second way of accessing systematic reviews for bronchiolitis in PubMed. And as I said, I just put bronchiolitis in my search box, search, and then in the filter column here, I just clicked on systematic reviews, okay? And then I got only the ones I want, bronchiolitis. The third way of accessing systematic reviews in PubMed, also through PubMed, is actually by writing here, PubMed via PICO. Now, PubMed via PICO, something called PubMed for handhelds, which you can actually download on your smartphone, من الاب ستور, من Google Play Store. You can actually download it in your smartphone and use it. Now, the PubMed via PICO has all the PICO elements: patient, intervention, comparison, and outcome. So if I put bronchodilators here, bronchiolitis, a medical condition often, and the intervention is a steroid, وأنا أيضا المرة دي أقارنه بsalbutamol, right? And I can select here whichever type of study, randomized or systematic review. For example, I want to do randomized control study and submit. Now I have 10 results looking at where they are mentioning steroids compared with steroids. Okay, so there are several: randomized double-blind placebo-controlled trial, nebulized epinephrine in children in a randomized study, prednisolone plus albuterol versus albuterol. This is what I want. Okay, now this is the study which is exactly what I'm looking for: steroid compared to with salbutamol compared to salbutamol alone. Albuterol is salbutamol. The interesting thing about the PICO is that they have something called TPL. TPL stands for the bottom line. The bottom line, TPL. So it says here, in patients evaluated, right, where there was not detectable, there's something missing here, okay? Suggesting that the addition of prednisolone to salbutamol transiently accelerates recovery from bronchiolitis. So this is called the PubMed via PICO. Another way of accessing, and it has the TPL, the bottom line. I can go back and actually say, I don't want randomized, I actually want systematic review, and I check, right? And this is actually the systematic review where they are looking at salbutamol or bronchodilators in bronchiolitis, okay?
Bro, time.
أيوة. أيوة.
We just give you 7 minutes.
Sure, أنا تقريبا بقى 7 minutes بخلص. The third way of actually accessing systematic reviews is the TRIP database. Again, in Google, I went to the TRIP database. Wow. Now, TRIP database also has a PICO. You can see it has also its own PICO. But I can put bronchiolitis here, right? And I get 10,000 results. But on the side, I have guidelines and systematic reviews. I can actually just put systematic reviews, click on systematic reviews here, and then it filters only the systematic reviews for bronchodilators, for bronchiolitis. So I can access systematic reviews through Cochrane, through PubMed, clinical queries, through PubMed and the limits option, through PubMed via PICO, and through the TRIP database. Now, I want to see how should I manage bronchiolitis. I want a pathway to tell me how to manage bronchiolitis. So what I'm going to go is something called NICE pathways. Now, NICE is the guideline website for in Britain. Now it has pathways for all the medical conditions. Now you can see here, these are the medical conditions where there is a pathway, right? And I can put bronchiolitis here, right? And it tells me a stepwise approach in diagnosing and managing bronchiolitis in children. I have a bedside resource for answering all my questions on bronchiolitis. Okay, these are called the NICE pathways, and they are free, available for everybody, right? I want also to go to another point of care resource like the BMJ best practice. So I go to Google and I have BMJ best practice, right? And sorry, logging, right? So because I have access, so I can actually just put bronchiolitis here, and I have all the evidence information, right? Even patient leaflets and everything, how to manage. And I have a PDF as well. So I can provide patient information, right? Or I can have all the management of bronchiolitis in the epidemiology, etiology, case history, prognosis, monitoring, treatment algorithm. So I have everything I need, first line, second line, and so forth. Supplemental oxygen, ribavirin, oral steroids, supplemental oxygen. So it has everything that I need to actually manage. And you can see that I have also calculators here. I can access calculators for these patients, right? And I can, if I have any problem with, for example, drug interaction, I want to see drug interaction, I can go to Medscape interaction checker, right? It's Medscape, there is a drug interaction checker, which I can add whatever drug I want, steroid, for example. Prednisolone. I can add another drug, for example, aspirin, whatever. And then the interaction found is automatically comes. So while I'm seeing the patient and can look at drug interactions or dosages, okay, I can look at pathways. So in essence, what you have during your ward round is that you can actually access all the literature you need, right? You can start by systematic reviews. You can go to NICE pathways. You can assess drugs interaction or drug dosages in Medscape. You can go to calculators in Medscape or in BMJ best practice and make calculations. And let me just go back. What happened? ما أعرف طلعت منها. هل معايا الناس ولا ما معايا؟
معاك يا بروف. خلصتها؟
لا خلصتها بارك الله فيكم. So I gave actually a short like information about how to quickly access information in when you are actually.
Thank you, Prof. It was very nice talk. Thank you, Prof. Imad. and thank you, Prof. Karim. I think we have about 13 or 12 questions here. Is it clear for you the questions? Say I read them for you, or you can read them immediately from Q&A. The first I assigned,
yeah. They are very clear.
Yes, the first 6 questions is from for Dr. Karim. Question from Dr. Marwa Jalal and Dr. Ali, and 2 questions from Dr. Marwa Jamal, Dr. Ali, Dr. Hashim Azzuddin, and the first question of Dr. Taysir. You can answer the questions, then the next 6 questions, and there's other additional questions for Prof. Imad.
So again, thank you very much, Dr. Waliddin. Thank you very much, Dr. Imad, for this very valid and useful talk. Waliddin?
Yes, Prof. Karim.
Thank you very much, Dr. Waliddin, for your for this chance again, and thank you a lot, Dr. Imad, for this valid talk and useful talk. And thank you very much, Dr. I have a question from Dr. Marwa, Dr. Taysir, Marwa Jalal, a question from Dr. Ali, Hashim Izzuddin, Taysir. Thank you very much for this question. I'll just try to answer randomly, because I don't know what's the first and what is the second. Waliddin, are you with me?
Yes, I can hear you, yes.
Regarding the sample size, one question is, what about the total coverage? This absolutely unaccepted and forbidden, because total coverage will never allow you to draw a conclusion for your work. You will never generalize the result according to the total coverage. This total coverage may be under the requested sample size and may be oversampling also, so it is a waste of time and waste of material. So this total sampling is not accepted by many authors. And even publishers, they sometimes reject because of this. Another question is, can we utilize previous sample size in similar study? Yes, generally I can say yes. Yes, we can accept this to some extent, provided that the variables are different. Because if it is the same variable, that means we are going to repeat the result. But otherwise, it is okay. One question is, I think, is regarding research question. The approach of PICO, P for population, I for intervention, C for comparison, outcome, and time. Yes, this is acceptable. I think Dr. Imad might elaborate if he, I'm sure this is his area also, and they know it more better than us even. So
try to raise your voice, Dr. Karim.
From the beginning, or? Hello?
أنا سامعينك يا دكتور كريم.
سامعينك، أنا سامعكم بس والدين ما سامعني، ما بيحتاج تتلخبط بعد. فأنا سامعكم، والدي ما سامعني.
Now the voice is good, yes.
My voice is good. Can I repeat from the beginning? I say regarding the total coverage is unaccepted by many authors. Many authors, they dislike it because total coverage either will give you undersampling or oversampling. If it is undersampling, you will never generalize your result. You will never draw a good conclusion, a reliable and valid conclusion. If it is oversampling, it's a waste of time and waste of material. Regarding the PICO approach for generating research question, it is good, it is okay. And as I mentioned, Dr. Imad might add on this area, PICO, B stands for population, intervention, comparison, outcome, and time. It is okay. Regarding another question for using the same sample as used by previous reviewer or previous manuscript, it is okay, provided that the variables are different. If the variables are the same, that means you are going to repeat. I don't know what other further question. The comment of the reviewer. The comment of reviewer is very important. The reviewer will tell you why they reject. I think they are honest. If they reject, they build this on a strong basis. So they will tell you, for example, your language is not good, your analysis is not coinciding with the design, and so forth. So it is very important to look for that. One question also: how many articles do need I read so that to prepare my meta-analysis or review? By the way, the difference between systematic and systemic review. Also, this is an area of Dr. Imad. I think he can elaborate also. So I can't say certain number of articles or journal are needed to generate this review article or systemic review or meta-analysis, but the much is better. Like the sample, if you have a small sample, this the conclusion might not be adequate. I hope I answered the question or the questions. I think also.
Yes, thank you, Dr. Karim. There's other questions, you may answer them after Prof. Imad.
Okay.
Right. أنا في سؤال برضه من دكتور تيسير على should I review the primary and secondary literature, systematic reviews to raise the chances of paper publication? By all means, you should refer to systematic reviews. And they يعتبروا the highest level of evidence. Whenever you are actually publishing a paper, especially if it is relevant to one of the systematic reviews, right? By all means, include systematic reviews in your paper. Okay. Does it increase the chances of a paper publication? Not at all, but at least it tells that people that you are aware of these important concepts. paper acceptability فيها factors كثيرة. قال الدكتور كريم الدين ما قصر بارك الله فيه وراكم الأشياء المهمة for the paper to be which people use to reject the paper. دي الحاجات اللي تستفيد منها. Cochrane library. Cochrane library you can access an abstracts for free. You can also access an abstracts for free من PubMed. لكن اللايبرري نفسها فيها material you can only access if you pay. I'm not sure في السودان عندهم ناس هناري عندهم الحاجة دي for free ولا لا، لكن you can access an abstracts for free. A library you have to pay. دكتور حمزة عنده كده مشكلة مع الاي بي ام، لكن انا بقول لك يا دكتور حمزة الاي بي ام ده هو الحاجة اللي بيمشي حس الهيلث كير. اديك انا مثل هسه انت لما تيجي بتصلي ركعتين ولا 4 based on evidence. من باب اولى تعامل المريض تعالج المريض من الايفيدنس. فما تشتغل يعني انت ما على كيفك تصوم رمضان في شهور الشتاء، ولا تطلع الزكاه اقل، ولا تصلي ركعتين وهي تصلي الصبح 3 ركعات وهي ركعتين. Use evidence for your religion. للدين use evidence. For practice to prevent harm to patient use evidence. ده لأنه الحياة أو الروح مقدمة. evidence based medicine فيه 3 components: best available research evidence, patient values and preferences, and patient expertise and personal expertise. بروفيسور مغربي جزاه الله خير وبشكره على حضوره معنا. Personal expertise is part of evidence-based practice. We believe in evidence in personal expertise. بالذات في السودان ما عندنا results of studies. Personal expertise مهمة جدا. Aim and objective in research methodology. طبعا aim what you want to achieve, objective is how you're going to achieve it. هذا الفرق بيناتهم. Your aim, I want to assess malnutrition. Your objective, I'm going to assess it using these tools. فده الفرق بين aim and objective. Aim is the final outcome you want to do. Objective, how you're going to do it. Which is more recommended to use, PubMed or Cochrane? PubMed فائدته إنه بوصلك لكل حاجة. you can access PubMed, you can access Cochrane من PubMed. لكن أنا مثلا عندنا مشكلة بتاعت heart failure. عايز أعرف مشيت شفت all the systematic reviews على heart failure. طلعت لقيت more than 100 publication على heart failure systematic reviews فشفتها واحدة. so that we provide care that is evidence-based and based on systematic reviews. فكوكرين هو الفيرست one to access لأنه هو trustworthy systematic reviews. PubMed يجيب لك كوكرين وغير الكوكرين. How far does one person experience هذا أجبته لأنه evidence-based practice is برضه فيه personal experience. تاني can we know how long is your ward round? طبعا أنا because I have been doing it for years and years, my ward round is actually one of the fastest and the most effective الحمد لله رب العالمين. هذا فضل من الله سبحانه وتعالى. يعني I do my ward round طبعا بيعتمد على عدد المرضى، لكن مثلا on average أنا بيكون عندي between 15 and 20 patients when my ward round takes around 3 hours. وأنا my ward round starts with a sitting ward round وأنا I sit with my team. The ward round is actually for patient care and for teaching. There is no ward round without accessing the literature. يعني ما عندنا ward round ما بنفتح الانترنت دي، والحمد لله رب العالمين عندنا بنقعد قدام الكمبيوترات حقتها يعني في المستشفى، ونستعمل السكورينج تولز والكالكوليترز والدراج انتراكشن تشيكرز والاشياء دي كلها بنستعملها في الوورد راوند. لكن for around 15 patients it might take me 3 hours. ولكن believe it or not, 3 hours دي actually 2 hours are actually with sitting in front of the computer, and 1 hour actually seeing the patient. Our round is patient centered. We inform the patients of the plan and everything. في سؤال لدكتور كريم هنا.
طيب okay, thank you Prof. Imad. There is some specific questions you may forget. I want just there is a question to Dr. Karim from I hope if you can record these questions, Prof. Karim. There is a question from Dr. البحث Saleh. How can we calculate sample size if the study is not about the prevalence? And there is another question to Dr. Karim, and as well to after a comment from Dr. From Dr. Al-Hadi Miskin. His question is directed to SAP and Prof. Karim and Prof. Imad, both all of you. How is going to address this issue and any strategies adopted to the society, adopted by the society and responsible bodies to address these pitfalls? After a comment of empowerment of our research in certain areas or research-related areas like plagiarism, rhythm checking software choice for suitable journals, ISI journals preferable, and field-related research as possible. And before that, the fund. So you can respond to these questions before we can address some other questions.
Thank you very much. Thank you very much for this question. Also, I will share with Dr. Imad to welcome Professor Maghrabi. It is an honor for us, for all of you, and for our senior staff like Prof. Maghrabi and Prof. Al-Haj, Hamad Al-Haj Al-Awad. I have seen him. I have seen his name now. It is our pleasure for our senior staff to follow us, because this will encourage us and encourage our junior staff. One of the question is calculation of sample. What I have mentioned is just for the issue of prevalence. But for example, if you have case study, you don't need to calculate sample. If you have series of case study, you don't need to calculate the sample. What I mentioned is only limited for that thing, for prevalence issue and incidence issue. Another question, if they reject my paper, what I will do? You will submit to another journal. Nobody is free of rejection. Nobody is free of rejection. And rejection is not a bad sign at all. So if your paper is rejected, take the opinion of and the comment of the reviewer and send it elsewhere. Coming to Al-Hadi, Dr. Al-Hadi Miskin, الحقيقة Dr. Al-Hadi is obstetrician and medical educator, and he is interested in community education, community-based education. Graduated from Jazeera University. He has a lot of work in community work, and he was giving a lot of help to registrar doing thesis. So he's very experienced about the difficulties in thesis. So this is why he touched the issue of accountability and the issue of commitment of the association and the issue of Pediatricians aware of that problem. So I share you, Dr. Al-Hadi, with this concern, and I am sure our colleagues in Sudan in this very difficult situation, and in general, our association, SAM in particular, they exert a big effort try to help the registrar. I gave a previous suggestion to our association. I will repeat it again. I think it sounded repeated. How many paper has been published by pediatrician? I think more than 5 or 6 or 7,000. Why we'll collect? Why we'll not collect it in a book, and we call it Sudan Indicus or anything? اللي هي بالعربي الفهرسة. We have great authors. They wrote a lot of books, a lot of papers. Why you collect all these things and put it in our library to make it available for our students? And even want to disseminate the knowledge of publication. Now, Dr. Imad, he used the language of Cochrane, PubMed, ISI, Scopus. What are these? 20 years, I don't know what is it. And at that time, I'm not so keen to know it. But now I discover I'm even ashamed for myself. So we want our students to follow with the same chain which we followed in the past. So this is a role. I am very glad, actually, from the effort exerted by our colleagues in Sudan, who understand the situation there, the difficulty you face. We pray for God to help you and to add more and more, inshallah.
Thank you, Prof. Karim. Before I give a chance to Prof. Imad, yes, I want to thank the Sudan Association of Pediatricians and those who are concerned with our journal. As you know, our Sudanese Association of Pediatricians journal, Sudan Pediatric Medical Journal, is the only Sudanese journal currently is indexed in PubMed. We hope that we go well with other journals. Prof. Imad, there are two specific questions for you. There is a question from Ashwaq Ibrahim. She asking about the difference between systemic and systematic review, if there. And as well, there's another question about what do you prefer in systemic review? Is it Cochrane or PubMed?
Right. ابتدي بالاخيره. طبعا كوكرين is the number one resource for systematic reviews. عشان كده by all means. يعني مثلا لو لاحظت انا اول حاجه فتحت عليك في البرونكيولايتس كوكرين، وبعدين انا لقيت كل الاجوبه هناك تقريبا. يعني الان هم بيقولوا up to 30% of the 2-year-olds up 1 or 2-year-old will get bronchiolitis. يعني انت you really need to know the in-depth bronchiolitis. ما على كيفنا. This is our responsibility to our patient. فالان الكوكرين انا اخذت برونكيولايتس وافتح الابستراكت بتاعتها هعرف كل الحاجات، لكن الكوكرين ما فيه كل السيستماتيك ريفيوز. بفتشها وين؟ بفتشها في PubMed. وفي PubMed عندي 3 طرق، يا اما اشوف الكلينيكال كويريز او الليميتس او الفلتر بالجنب دي، او امشي PubMed فاي بيك واطلعها. لكن ابدا بكوكرين لانه هو نمبر 1 سيستماتيك ريفيو ريسورس. هذا واحد. فعايز اشوف سيستماتيك ريفيوز غير الكوكرين اقوم امشي PubMed. السؤال بتاع سيستميك وسيستماتيك. systematic معناه is done with a specific methodology. يعني الميثود بتاعت ال selection of articles, analysis of the articles, the conclusions كلها اتعملت بميثودولوجي. ولو فتحت كوكرين هتلقى فيه الميثودولوجي بتاعت كوكرين how to do systematic reviews. systemic review هم مرات يسموه narrative review. narrative معناها تجيب كلام من هنا وتجيب كلام من هنا وتجيب كلام من هنا وبتطلع ب like consensus على حسب مزاجك. السيستماتيك ريفيو ما كده. السيستماتيك ريفيو بالحساب، بيحسبوا الحاجه بالضبط، يشوفوا which one is good, which one is bad, whom to believe, whom not to believe. ف systemic او narrative review ده اللي احنا كنا زمان بنسويه، مثلا احنا طلبه نقرا الحاجه في كم كتاب ونلخصها في كراسنا، ده اسمه ناراتيف ريفيو. ما له علاقه بالايفيدنس بيس ميديسن اللي هو سيستماتيك ريفيو. فسيستميك ريفيو اذا بس فتحت الساينس او الانفورميشن الارتكلز وجمعتها في حته واحده، فده بيختلف ده.
Thank you, Prof. Ahmad. Thank you, Prof. Karim, and thank you, Saab, and thank you all these IT experts who help us. And I will get this chance as well on behalf of Dr. Safa, the President of Sudan Association of Pediatricians, and all the Executive Committee of Sudan Association of Pediatricians, to thank you. And as well, this is a chance for me to thank Dr. Mudathir and thank Al-Muhandisa Engineer Rayyan, who helped us in the technical issues. And we wish all of you get use of these lectures and valuable lectures. And we will hope to meet every week. And it is possible that we can change all Sudan and we can change our life. And always Sudan Association of Pediatricians is in the lead. Thank you, all of you, and goodbye. Thank you, Prof. Ahmad. Thank you.
بارك الله فيكم، مشكورين موفقين ان شاء الله.
شكرا جزيلا.
Thank you very
شكرا
much,
جزيلا.
بارك الله فيكم. شكرا.
Professor Ahmad. Thank you very much. Thank you, Dr. Karim, for the elegant talks, and thanks to our moderator, Dr. Walidin, and all the organizer committee. Thank you very much.
مشكورين، بارك الله فيكم، موفقين ان شاء الله.